Hello, hello everyone, and I'd like to welcome you to another webinar hosted by Thought Technology to help keep all of you guys in the know when it comes to clinical and research related topics, especially those related to this COVID-19 situation that we all seem to be experiencing. I'm very excited to be able to introduce Dr. David Arroyo, who's going to be presenting on the psychophysiology in a new reality, medical and psychological applications facing new paradigms in a COVID-19 world. For those of you who do not know him, I met him about 5 years ago, actually in Rome. We were just reminiscing on that. But Dr. Arroyo has 15 years of clinical and teaching experience, both Mexico and internationally, in hospitals, education centers, and government institutions. From integrating clinical psychophysiological interventions at the StarMedica Centro Hospital in Mexico City to founding the Mexican Society of Bio and Neurofeedback, his efforts both in private and public clinical work rest on developing evidence-based applied psychophysiology. Without any further ado, David, I'd like to let you take over and go ahead with your presentation.
Thank you, my friend. Long time no see. Hope to see you soon. Maybe in the next BFE meeting, hopefully next year, if things go in the right way. Good afternoon to all of you. For me, it's a pleasure to read you from the country that in the past had given the world a completely different meaning of the word corona, until the arrival, of course, of COVID-19. I hope to return to the old meaning of the word corona in the near future, maybe to have a little beer with all of you in some future meeting or something. But right now we are stuck in this situation. Also, for me, it's an honor to be here with you sharing my point of view about what I consider to be the present and the future, at least in the medium term, of applied psychophysiology in this new reality we're facing, and why I consider that it has the potential to become a fundamental piece of the puzzle of what will involve developing a new paradigm in health science, of course, always based in scientific evidence, and that consequently will affect our professional practice. I would first like to thank my great friends at ThoughtTech for considering me to participate in this great series of free webinars, for the commitment they have shown to the development of the discipline, even in these difficult times for everyone. I also consider it important to mention that when I speak of applied psychophysiology, I am referring equally to the practice of both biofeedback and neurofeedback, and even to the training and techniques that refer to the promoting comprehensive training, functional self-regulation, whether or not specialized technological equipment is used, for example, when we teach breathing techniques and all that. But of course, technology always does help us a lot to give us objectivity and direction to what we do. So that's when I mention applied psychophysiology, I think that's good to understand. I'm both referring to bio-neurofeedback and all the rest of the techniques involved in training self-regulation. Also, it's very important to say that everything expressed in this webinar, it's my own informed opinion based on my professional experience and field of expertise, unless otherwise indicated with the corresponding credits on the slides. These opinions do not follow any commercial commitment with any kind of brand or anything. My work affiliations, as John mentioned a few of them a few minutes ago, I'm CEO of Mindful Neuroscience Center, which is a clinical care and professional training center. I'm also at StarMedica Hospital here in Mexico, where I have my private practice. I was former head of the hospital psychology service and former president and current advisor to the Medical Bioethics Committee. And my main line of work right now is in the university, in Universidad del Valle de México, Universidad of the Valle of Mexico in Querétaro. It's a city near Mexico City, where I'm professor, researcher, and head of the Applied Psychophysiology program. Most of my work have always done it in Mexico City, but as probably you know, 3 years ago, we were hit with a very, very, very hard earthquake that make work a little bit difficult, because in the zone where I work, even the hospital suffered some minor damage and buildings fell from that part. So I been living in Querétaro for not in Mexico City for a couple of years right now, and surely when things started to go better here in Mexico, right now we're hit with this corona situation. So that's why I was inspired to talk about how to deal with applied psychophysiology in situations when we don't have as much control as we would have it, we think to have it. For example, when we are facing natural disasters or maybe even a pandemic in the way that we are facing it right now. Also, I would like to, I think that it's fair to mention that there are no professionals there are a lot of professionals with different fields of experience that can be useful in the face of what we are experiencing today. But the reality is that there are no experts specifically for what we are facing. The last time we faced a pandemic this magnitude was 100 years ago, and the conditions were completely different in every aspect. So it's very difficult to us to really make a direct copy of the experience from the past to the present day. So once again, it is important to consider that the only way that we have to get through all of this is by teamwork, because as I said, there's no completely experts in the SARS-CoV-2 pandemic or coronavirus pandemic of the way that it's named right now. So there are no experts, and that's why I think it's so important for all the people involved in the discipline to pitch in the ideas and to promote a right and safe way to work. So I think that's very important to say it, because there are no experts. First of all, I would like to talk about quickly what it's a paradigm. It's a word that it was introduced by Thomas Kuhn in 1962 in his book, The Structure of Scientific Revolutions. And paradigm is the scientific achievements that for a time it will provide a model, problems, and solution for a community of practitioners. When a certain paradigm doesn't longer answers the questions that we are asking, or if its answers are not satisfactory in the way that of the things that we are facing, it's time to shift, to change the paradigm. It's time to find new ways to think more adequate for the situation that we are facing, and that's how science has always evolved. And not only science, I think that it's fair to say that almost every part of the human mentality and the human thought has evolved is by answering each time new and new questions, each time that we face a new problem, or it's time to change the reality that we are living as so we are facing it right now. What's the current situation of health sciences all around the world? If we think about it, it was 1948 when the World Health Organization showed us the first definition of health, which was a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It was 1948. Even the Beatles were just young kids, and they haven't even flown to Germany to start playing. And even though it was not so far ago, it has been a long time. And they already mentioned that to have a good health situation is not just not being sick, physically sick. It involves being functional in the situation that we are facing. It doesn't matter which situation it is, but to have a good health also involves to have the ability to face in the right way different situations that might come upon us. But the truth is that the current model of clinical process does not fulfill its mission in the right way, because many health specialists still consider the human being only as a biological entity. If you are not sick, physically sick, then you have good health. Sometimes the clinical process is addressed as a step-by-step linear process when it's not in this way. There are many variables that are involved in the clinical process, and it's a dynamic, ever-changing process, because we can find new data about our patients or clients in every session. So the clinical process must be dynamic in every way, and also because multi and interdisciplinary work is not encouraged or applied. Myself being a psychologist, it was very hard for me to get into the hospital environment, because 10, 15 years ago, for, at least here in Mexico, the role of the psychologist was not very well seen in the hospital. Right now, we are an integral, a central part of the dynamic in the hospitals here in Mexico. Things have changed a lot in the past 10 years. I don't know in your countries how the situation has evolved in this time, but at the beginning, when I just started, the role of the psychologist and, of course, of the psychophysiologist, it was not even known. The psychologist was not where we were not appreciated, for saying in the right term, in the hospital environment. But also there was a very important part that involved that psychophysiology was not known in the medical world, at least not in a broad way here in Mexico. So I think that's the truth about the situation, that I've heard that it's more or less the same in a lot of different countries. There's also one problem. The current model does not fulfill its mission because it underutilizes the full capacity of the resources that modern scientific and technological advancements can provide, or it relies too much on these developments and dismisses the human dimension of the patient or client and most of the factors and variables that play a key role in attaining a real state of well-being when it's possible. We have to achieve this right equilibrium between using in the right way all the marvelous technology that we have right now, but also we have it's very easy to go to the other end when we rely too much on this technology and we forget that we're dealing with human beings. So a few years ago, I found this definition of health that I think that applies very much to our discipline, to applied psychophysiology, because it involves not only the well-being from a physical point of view, but also that we can function in the right way in our society, and we can achieve a right performance of the activities that we do. So from my point of view, and that's the way I teach it to my students, and that's one of the mottos I follow in my clinical practice, a dynamic well-being state characterized by physical and mental potential that meets the demands of life according to the specific requirements for age, culture, and personal responsibility. So it's not just a very small part to define what applied psychophysiology is related to health. I think that this, as I told you before, this definition is very well suited for what we do, because we do not only treat disease as applied psychophysiologists, we do not only treat dysfunction, but we also train people to work better on their environments, and that will be a key role in the future, in the post-corona or in the corona world right now. I think this definition of health, it's very important to understand where we're standing right now. Of course, if you are a psychologist, and I think that this is one of the graphics that it has been written all over in the introduction to psychology all over the world. Right now, we believe the human being to have, of course, a biological, social, and psychological dimensions. It's a very easy to understand chart of the different dimensions of the human beings. There are also other people that think that there are more of these three, but in a broad sense, even from the psychological point of view, not dealing with different ways of thinking, of different schools of thought or psychology, I think that most of them agree in these 3 points, that we have a biological, a social, and psychological dimension that we have to really take care when we're treating patients and when we're treating with our clients. Because all of these human dimensions coexist in a balance. If one fails, the system fails, and the subject simply does not function. These 3 spheres of functionality most need to work in a balanced way. And when I mean in a balanced way, I don't mean that there always have to be straight in the like this pencil, and or if we think of a pendulum, that the pendulum always stays in the middle. I think that when we talk about health and in every way, normality or functional normality always tends to go to it's not always functioning in the right way. It's normal to dysfunction in a certain way or in a certain amplitude at some point of our lives. Of course, as the pendulum swings farther and farther, then we can face situation that needs more and more attention, and that we can consider it pathological. Not everything that was considered pathological in the past should be considered pathological right now, and we will see why in a few minutes. And also, we have to take into consideration how COVID-19 affects people. And I'm not just referring to the respiratory symptoms and all that. How does really COVID-19 affects? I think that it has made evident the poor health state of health in a large part of the population, and even more so in certain communities, because as we know, the people who doesn't have a good health state, that has health problems, are the ones who are most likely to have complications, even fatal complications of the disease. So to have a good health is very important, and even the death rate and the complications and the case where intubation was necessary, it has put in evidence that as a society all around the world, we cannot say that we have taken good care of ourselves lately, and I think that's a very important point of view, and one of the points where applied psychophysiology can be very, very useful, not only as reactive to the disease, but also as preventive to the different diseases and complications that COVID-19 may bring, and of course, many other diseases. It also affects because it's a multi-systemic and multi-organic disease that affects maybe we can say it with affectations that potentially transcend the acute stage if present, converting it into a chronic process because it alters the functional self-regulation of the organism. I remember a few months ago where the only thing that we heard about COVID was the respiratory symptoms. Right now we know that it affects all it, because of the way that it changed coagulation and all that it can affect almost every system in our body, and it affects in a different way, but in a very hard way, different organs. So right now we may be facing a possibility that even the people that has survived, or even the asymptomatic ones that already had the COVID-19, maybe they don't have enough symptoms to consider that they were very ill. But we don't know if in the near future, or maybe in 20, 30 years, the people that suffered COVID may be more likely to present other kind of chronic diseases. In the neuroscience, we can see that in different, for example, different infection, all that people may be prone to develop neurological diseases over the years. Maybe in a few years, and right now I'm just writing in the air because we don't know. But maybe in 30 years we will find another kind of dementia made for people who suffered COVID-19, and at the moment that they suffered the disease, it was not as bad as we thought, but maybe a few years later, things could turn to the bad side, and even liver diseases or kidney diseases in the same way. So we're not just facing the acute symptoms of the disease as they show up. Maybe we have to think in the future that there could be some situations that could develop more chronic diseases in the long run. And also for the people who were very sick and were in the hospital and need to be intubated and all that, we are facing very slow functional recovery. I've just seen a couple of days ago a picture of I think that it was a nurse from in United States, that he was very, very fit. He used to do a lot of exercise and all that. And he showed a picture of him before the disease and after the disease, and he his physical appearance, also of course his physical situation, his health situation was really affected. And we're talking about a person that was really physically fit. So we're maybe and taking into consideration, as I talked before, that not everyone is as physically fit in different countries all around the world. Maybe we are facing a reality when chronic diseases could be appearing that was related to maybe a past of suffering COVID-19 in the future. So I think that's a very important thing to take into consideration. Also, it affects both those who suffer from it and those who do not, because we have a secondary social effect, affectation, people who are in quarantine in their homes, or people that, of course, they have a social and economical bad outcome of this pandemic, and that just by being anxious or nervous about with all the uncertainty that follows a pandemic of this size. At the same time, this situation also affects the physical part, so it becomes a vicious cycle. It's very important to understand that it's not just people who were sick. This situation has sickened even the ones who were not sick. And we are facing in the near future, as a lot of different publications and universities has talked about, maybe a future where we will be facing different psychological or psychiatrical diseases. So I think that's a good thing to also keep in mind when we talk about COVID-19 and when we start thinking how applied psychophysiology will fit in the future of this situation. In short, it profoundly alters a person's abilities to self-regulate in all functional areas, bio, psycho, and social. So it affects the way that we self-regulate to function in the right way in our world. That's in short how COVID-19 affects. But it has also altered the way that we conceptualize pathology. I was telling to my students a few days ago that if maybe 4 months ago a patient came into my office telling me that he was very afraid to go out to the streets because he was really afraid of catching a disease, and he was compulsory washing and cleaning his hands 20 times a day for 40 seconds and constantly using hand sanitizer and all that, and by thinking that if he didn't follow the right rules, maybe he will die or make someone he loved to die. Maybe 3 or 4 months ago, we will think about a different situation, maybe a different pathological situation, but right now we are talking about a desired behavior in that person. So it has changed the way that we conceptualize pathology, because I think that this was necessary. We are obliged not just to think about symptoms or signs. We have to really follow up to the origin of those symptoms or behaviors to really determine if something is pathological or not pathological. It may sound very logical what I'm saying right now, but the truth is that in the clinical practice, not everyone does this in this way. There are a lot of different people who only sees the symptoms or the signs and doesn't care about the origin of those, and that leads us to maybe an over pathologicalization of many of the situations that we address as applied psychophysiologists. For example, this is a graphic that appeared in Science a few weeks ago, and it shows just what I was saying in a few minutes ago. It affects everything from a systematical, multi-organic and multi-systemical. It alters the function of the body in a very wide range of ways. We can have of course, respiratory symptoms. We have metabolical and endocrinological symptoms and affections that involve the liver, the kidneys. Also, from the gastrical point of view, we know that there are signs from gastrical disease related to COVID-19. Even sometimes it's the only manifestation. Even dermatological situations that we are seeing in COVID-19 patients, but also from the nervous system, we have all the things that were described at the beginning, like the anosmia, the inability to perceive certain odors, and to lose the sense of tasting food and all that. But right now we are facing very different situation. We know that it's not the only way that it affects the nervous system. We are also addressing that it affects from vascular disease in the brain and could lead to strokes, for example, and other kinds of nervous system diseases. So it's very important. Even the eyes, the nose, the hearts and blood vessels. So we can see that COVID, it's a multi-systemic infirmity. It was said that polio and other diseases were the great impostors because they usually disguise themselves of many different diseases. Well, right now we are facing a new and very powerful impostor. COVID-19 is a great pretender, because it pretends to be very different diseases, and we have to educate people in the right way from now on to the future, that not every diarrhea is a gastrical situation, that not every respiratory disease it's a flu or influenza and all that. I think that, as I told you before, COVID-19 has come to change the way that we think about different diseases. Of course, that we can even think about, as the National Institute of Mental Health mentioned, and this is just an example because it shares symptoms with very different psychological and psychiatrical conditions. For example, here in this chart, we can see how anxiety and COVID may share some symptoms. And it's if in the past, many patients who come to the ER on the emergency rooms thinking that they were suffering from a heart attack, it turned out to be an anxiety crisis. It's very common for us who work in the hospital environment. Right now, the new heart attack, by saying it will be COVID-19, people will, by the slightest of the symptoms, may think that, okay, I'm having COVID-19, and they will rush to the ER. The trouble is that when people are suffering from a heart attack, they are not prone to infect others. But when we have a suspicious patient that is suspicious of having COVID-19, we have to take into consideration a whole different protocol, maybe with using of personal equipment of personal protection and all that. So it has changed even the situation of how hospitals work, even in the ER. If someone shows up with with diarrhea or a gastrointestinal symptoms, we have to first take maybe an X-ray, a chest X-ray, to see if there are no signs of COVID or something like that. Because right now we are a little bit paranoid that maybe everyone should be treated as possible COVID-19 carriers. And of course, they're not in the same way, but it spends a lot of the resources from the health science, from the health services situation to really to differentiate if we have anxiety or COVID-19, if we have depression or COVID-19, if we have an allergy of COVID-19, if we have food poisoning or COVID-19. So right now, all the efforts, even in the hospitals, they are working to get used to this new reality. Other thing that it's very important to think in this chart, it's just a brief example. Right now, we think that this number was from a month ago, so right now the numbers have increased. We don't know how many surgeries has been postponed or even canceled. We don't know how many treatments for other diseases that of course exist. Not everything is COVID-19, but there are a lot of different diseases who were not treated in the right way. So also in the near future, we're going to face the consequence of this, and we can see it in this other chart. The first wave is the immediate mortality and morbidity of the COVID-19 patients, but the second, we're going to deal with it, and it may be the ones that take us the less time to deal with it. But then we will have that second wave that it will consider the impact of the resource restriction on urgent non-COVID conditions. The third way, the impact of interrupted care of chronic conditions, the people with cancer, with kidney disease, with lung disease, not related to COVID. But the most important part is the fourth wave. And as you can see, it's the one that it would not go down. It's the one that it would be going further and further and further and growing with each year. And it's the ones related with with psychological trauma, with physical trauma, with mental illness, the economic injury that we were just talking about, and the burnout situation from the healthcare practitioners that are really burned from this situation. So where is applied psychophysiology going to fit in this panel, in this wide view, in this fourth wave? And it's very important to see that it's the only one who doesn't, which very different specialists for different universities all around the world and research centers, is the only one that they do not predict that we will go down maybe in the next 8 to 10 years. We are going to face a situation when right now kids that are going to be returning to their schools are not going to have the same social integration as before. The ones that we are going to be facing a new reality that maybe we are going to see the consequences of that in 5, 10, 8, 10 years from now, but also the other things that are mentioned here in this fourth wave. This is where applied psychophysiology fits. Because why do we consider that applied psychophysiology is very useful in this scenario? Because it promotes the functional self-regulation of the individual in all his functional spheres in a quantifiable and evidence way. It's not just from a subjective point of view. If we understand from our point of view COVID-19 to destroy this capacity of the subject or of the organism to self-regulate, we have to find ways to self-regulate back the ones who suffered from the disease. And as I told you before, not only them, but also the ones who, by the quarantine or by being at homes, they lose their capacity to self-regulate. Also, if we think about self-regulation as the best way to promote a good health state and all that it's related to all the immunology systems of our body, if we work in this way, we are going not only to help people who are recovering directly or indirectly from the disease, but also we are applied psychophysiology it's very good in promoting a good health of the individual, of the people, and in that way to make them less likely to have complications, not only for COVID, of course, that's what we are talking right now, but also from different diseases that may be chronic and related to many other situations and pathological situations. One of the most important things that we have to talk about applied psychophysiology and why does it work, it's a very simple idea. Having all the science in the back, and as you have seen, I'm not talking about specific protocols, but from the philosophical basis of the applied psychophysiology in this new reality. When people ask why does it work, and transcending all the scientific explanations and all the data and all the numbers and all the techniques and all the technology behind it, it's because it brings us the possibility to transform what was previously subjective into objective. We move forward for just asking the patient, how do you feel? To ask the patient how does he feel, but by seeing at the same time, in real time, how his organism is working when he feels in that at the same moment when he's telling how does he feels. That's a very important situation, because if you remember, we used to only analyze, for example, pain. And I think next week, Ralph Nichols, a student from Bernie Brucker, maybe will be addressing pain. I don't know, because Bernie Brucker was one of the pioneers of pain management in applied psychophysiology. But for example, until a few years ago, the only way that we have to measure pain in a person is showing him a list of numbers and an angry or colors, and asking him, how bad does you feel? How bad is your pain? But right now, we can also we can still ask the patient that, but we are measuring how does he feels when he feels that amount of pain. So it transformed the subjective into objective, and it gives us also objective tools to deal with this not self-regulating situation that people may come to our office. So it turns subjective into objective situations. Also, applied psychophysiology in its nature is not dogmatic. It's ever-changing, up-to-date, evidence-based, and open to new developments. If people still practice applied psychophysiology the same way that they used to be doing it 5-10 years ago, it's not the right way to practice applied psychophysiology. It's very, very exciting from my point of view to see that applied psychophysiology changes every year. Every year we are facing new discoveries. The technology is evolving. Right now we have the technology to have telepresence, to conduct sessions even from different continents, not just by being in different parts of the same city. We can practice with this new technology that it has become more and more affordable through the years. I think that, of course, it has to become more affordable for our patients, maybe, but we have the ability to not have the patient even in our office all the time, or 7 days a week, or 3 times a week. Right now, technology can make us maybe to have the patient once a week, or maybe once every 15 days, and then have this patient to work at home with this with certain devices, and we can monitor how he's working and how he is following the treatment, from the safe of not being as near as right now COVID-19 prevent us to be. I don't think that's the right way. I always think that to have the presence of our patient and to see our patients in our office is very important. But right now, we are not facing what we like. Is what we need to do to keep everyone safe. And applied psychophysiology opens up a lot of different possibilities to work not only from our office, but only from patient's home or at distance. So I think that's very, very important role of applied psychophysiology in this new reality. And of course, it's minimally invasive. It's my personal opinion. As I've said before, I don't think that applied psychophysiology is not invasive. I think it's minimal invasive, because when we deal with the way that the body works, and we have the ability to change the way the body works, we're not talking about non-invasive. We're talking about minimal invasive. Of course, when we're talking about pelvic floor applications, it's a lot more invasive, but in the general part, it's a minimal invasive technique and discipline. And right now and in the near future, the least amount of direct contact that we have with our patients, the most safe it would be for everyone, at least for the next 2 years. It's not the right way to work. I'm against not having a direct contact with our patients, but as I told you before, right now it's not what we think is best. It's what we know it's best to keep everyone safe. And that's a very important key role of applied psychophysiology in this new reality. Also because applied psychophysiology works with biomarkers, and transcending all the polemical points of view that we are facing, even with the DSM-5 on all the diagnostical manuals that they don't consider biomarkers. Applied psychophysiology, we work with biomarkers, and of course it bring us a more objective way to work, a more precise even diagnosis, and better techniques who are aimed directly to what we want to change in the way our patients' physiology maybe not working in the right way. So right now we are not only working with biosignals like the EKG or EEG or HRV, but we are also integrating some even laboratory studies, for example, the count of cortisol and all that. So I think that's very important and a very needed situation to bring into even behavioral science right now, to bring objectiveness into what we do. And what is more objective than biomarkers? Of course, we are a long way to really have a map of all the biomarkers for every condition that the human being may present, but we are in the right way, thinking that what we need to do is to develop and to discover these biomarkers so we can have a better approach to our discipline, our patients, and even our clients, if they are not our patients, for example, in the peak performance applications. It considers to practice applied psychophysiology needs to consider the synergic integration of medicine, of psychology, or psychophysiology, of applied psychophysiology, of neurophysiology, and applied neurophysiology. I think that the slide mentions all the different aspects. So the professional, it's a very well-trained professional. It has a lot of knowledge in different areas, because if we consider ourselves to be specialists in applied psychophysiology, this is what we need to know in our related to our field, of course. And let me ask, which doctor or medical specialist or which hospital would not feel really pleased to have this kind of professional in their teams? We have also to learn how to sell ourselves, because we are, in my opinion, we are one of the most complete health specialists that there are around, because we deal with people, with the things that MDs doesn't deal from, of course, if they are not specialized in this area. And we also deal with the things that psychologists do not only deal, and we also deal with this, the things that maybe even the physical rehabilitation specialists do not deal. And of course, we will find specialists in all of these different areas who will chip in with their ideas and with expertise from their direct fields to improve applied psychophysiology, making it better and to grow with each day that it passes. But we need to start working from a multidisciplinary point of view. And I think that's something that it's not working the right way up until now. Maybe these kind of events will help us to shape this situation. It also requires of science to verify the presence or absence of an objective or measurable situation that can affect the general or specific functionality of the subject. And also we need to consider art, caring for the subject in all of his human dimension, including non-objective or logical parameters. This is where epidemiology, clinical pathology, biostatistics, etc. insert science into the art of clinical procedure, making it more rational, because most of the time we will be trying to make the patient or client function within the standard of a normative data ideal according to gender, sex, age, activity. But at the same time, and right now I'm addressing what I was talking at the beginning about this equilibrium, about this balance. From the artistical point of view, it is expressed as the understanding of the patient or client and their circumstances, and the individualization of the treatment according to their needs. No two patients are alike, and no two patients needs the same or has the same needs. Also, applied psychophysiology gives us new tools to enhance and improve diagnosis, giving us more elements and more precision. Treatment and intervention from the psychological, medical, and integral point of view, from a comprehensive point of view. And also it gives us a lot of objective tools that helps us enhance and improve the follow-up. How do we evaluate the results in the long, medium, or short range of time? So it gives us a lot of different tools, applied psychophysiology, that we need to work with these three steps of the clinical process: diagnosis, treatment, and follow-up, most closely in what we do. What does applied psychophysiology seek? It seeks a better understanding of our patient and his functional circumstance. It seeks to promote self-regulation of certain neuropsychophysiological function, avoiding, when possible, more invasive or intrusive treatments. It also offers new therapeutical options that can replace or complement other methods to increase the quality of life of the individuals. That's one of the goals of what we do. And what doesn't it seek? It do not seek to replace the work of other health specialists when needed. It do not seek to replace other procedures which may be necessary or indispensable. We come here to complement many other, maybe to be the main therapeutical intervention for some patients, but also to help other medical or physical therapists or medical specialists to achieve the results that they want with their treatments when that treatment is necessary. It's not even we do applied psychophysiology or the medical treatment, because at the most basic level they are the same, but there will be times and situations where applied psychophysiological treatment would be the main line of treatment, and there would be times when it would be to complement other kinds of treatments. So we have to keep that open mind in what we do in our field. Because when your only tool is a hammer, everything looks like a nail. And we as applied psychophysiologists, specialists, we need to think outside of the box, not only to think that we only have one tool. As I showed you before, applied psychophysiologists have a lot of different tools, and sometimes we do not use them to their fully capacity. Why it has been so difficult to integrate the paradigm into the usual diagnosis and treatment schemes? Because other health professionals don't know about it or understand it. Too many so-called professionals in the field of applied psychophysiology equals to bad results, equals to notoriety, disrepute, and as I think that we have always heard in different fields about our discipline, it doesn't work. It doesn't work because people who are not doing it in the situation that they need to do it, or they don't have enough preparation to do it, or maybe they're using it wrong. And also implies a change in the role of the patient or client, going from a passive victim to an active participant. This may be the most difficult part of our discipline, because people are used to, I feel sick, give me my pill, give me my medicine, and my medicine works, and I feel better right now. Right now, we are talking from the applied psychological point of view, we're talking about a situation that requires a change of mentality, not only in the specialist, but also in the patient. The patient has to be clear that what he does, his role in the treatment is very, very important. Because if he is not involved in what we do, the treatment, as good or equipment as good as it could be, will not work as the way that this is intended. It also requires the specialist in applied psychophysiology to be exactly that, specialist. Therefore, the necessary knowledge to design a proper treatment for each patient is a fundamental requirement. Standardized protocols can be very useful guides, not step-by-step recipes. And right now, this is more important than ever, because we will be facing situations that no one thought 6 years ago, 10 years ago, even 6 months ago. So we are going to be inspired, and we are going to be based in standardized protocols, but we have to adapt to the certain need. We need to adapt those protocols to the needs of each patient. And that's why we can really, really become that key piece of the puzzle that health sciences will become in this future, in this reality, in this present, and in the foreseeing future. And all of this because applied psychophysiology is not just connecting sensors and electrodes. It's more than that. It's knowing where to put them, it's knowing what we're measuring, and it's knowing what we can achieve by changing what we are measuring with these electrodes and sensors. And that's why it really turn us into just people who put cables and sensors and transform us into real specialists that can achieve a lot of very, very good things to our patients right now when they need it the most. Clinical procedures, psychological, medical, peer performance could benefit from the integration of this paradigm into the traditional medical schemes or in traditional health science schemes. all those which could benefit from a better understanding of the patient and his functional circumstances, a more precise diagnosis, and having the opportunity to design more effective and comprehensive therapeutical procedures and treatments. We can also benefit because we will have greater objectivity in the evaluation of many elements that could be considered to be subjective. We will, if we do the things in the right way, we most likely have a patient or client more committed to their treatment, intervention, and their active role within it. And to be short, we could benefit all those with the potential to regulate certain psychological function, most of which have a behavioral correlate and vice versa. So in reality, it's a comprehensive treatment. It's a comprehensive approach of the subject. To wrap up the final ideas of my final ideas about this subject, it's applied psychophysiology is neither a universal solution nor a panacea. It is vital to determine the feasibility of the treatment and intervention according to multidisciplinary clinical diagnosis process. It provides us with the potential to offer new options for more effective treatment or where appropriate to complement existing options for increasing their effectiveness. As I told you before, it's not just as a primary intervention, but sometimes it would be a primary intervention. Sometimes it would be a secondary intervention that we promote that the primary intervention works better. So we have a lot of different things to do, not only when we are the main treatment. To be a good professional in this field, we require both knowledge and clinical skills, and the commitment of the patient to take an active role in his treatments. Of course, there is much to be done, and right now we are not sure of what we will be facing in a few months ago, in a few years ago, but we have to be ready, because one of the most difficult parts of what we have dealt in the past 6 months is that we were not ready to face what we are facing. Right now, it's a wake-up call to be ready to at least be ready to face what it may come in the next months or even years. We have to have this responsibility as professionals of our fields. And also another problem is there are a lack of true professionals in our field. There are a lot of people who think that only having a few maybe webinars or maybe a few workshops, they are already specialists. The real specialist in applied psychophysiology is the student all of his life. Please always doubt of someone who thinks that they already know everything, because there's no such person. We are all students of our field, as Jay Gunkelman says, he says related to the brain, but we are all students of our field. That's a very important point of view. And right now, to wrap up, I leave you with this a small quote that I found a lot of years ago in a book. I haven't found that book ever since. I'm very lucky to have it copied the quote, because I haven't found the book. I searched for it all over the web even, and I found the quotes, but I haven't been able to follow the book. I don't know if all of the book is good, but I fell in love with this quote, and that's the way that this quote represents the way that I deal with my personal and professional responsibilities with my patient and with my students. It says that, therefore, the clinical art lies in performing some essential activities well enough to provide healing to the sick whenever that's possible, the maximum relief when healing cannot be achieved, and the maximum comfort when relief is not even possible. I think that this is a very poetical point of view, but it resumes the responsibility of the applied psychophysiologist specialist. It's by Manuel Bañuelos in a book called The Clinical Art, and I leave you with this final idea of what we are dealing in our discipline. Thank you very much for your attention. I hope that this small webinar has give you some ideas or something to think about. I would not like for you to totally agree with me, But I think that the goal of this webinar was to make us think what would be the role of the applied psychophysiologist in this new paradigm involving health sciences. If I'm able to do that, then I think that I have achieved my goal. And for me, it's everything. I don't know if there's any questions. It wasn't on my screen, the questions and all that. Maybe
No,
John.
that's okay. Thank you very much, David, for the presentation. Thank you very much for everyone who's been listening and sending in some questions. We do have some questions coming in here, and so we're going to go back to maybe one of the earlier ones before we get to a lot of the questions coming in right now, focused a lot on biofeedback devices and methods. But going back to the initial start of the presentation, someone asked if we practice evidence-based, if we have an evidence-based practice, should I say, wouldn't that help us adjust to the changes like COVID with more ease? Do you think maybe there's a method of evidence-based practice that are taught, such as by Dr. Sackett? Could that be helpful? I don't know who Dr. Sackett is, unfortunately.
I think that, of course, I'm always in favor of evidence-based practice in applied psychophysiology. I think that one of the most harmful things that has happened to our field is that we have a lot of different practitioners do not follow evidence-based. But right now we're facing a new reality, that it was not gradually put in front of us, that we can say that it was a reality that was imposed from one day to the other. So right now we are lacking of evidence-based things because we do not have the right experience to really to be sure of how these things would be, how to deal with this situation, or even from a medical point of view, they're not even sure that even if the medicines that they are trying right now, they are really useful for every patient or for some kind of patient, or in the long term, it maybe cause more troubles than that advantage. So right now we are dealing with that kind of situations. Evidence-based should always be our standard, and multidisciplinarity should always be our goal, because we don't know everything. If we work closely with MDs and physical therapists and psychologists, we applied psychophysiologists, we will have the right tools and materials to develop the right treatments, and to have the evidence to see if the treatments truly work in that kind of situation. But the truth to be spoken, right now we are still lacking of experience of many other things. So when we are lacking of experience in these things, I think that to address the treatments, even potential treatments that has not been researched from an ethical point of view, should be the way to help the science to advance. So right now we can say that we are lacking of the evidence that we would love to have.
Okay.
Maybe in a couple of years, but we are in the right way.
Thank you. Someone else is asking, do you think that there may be a second wave of COVID, that the negative effects we already see now are just going to be exponentially multiplied in terms of that psychophysiological response, or that maybe people who are kind of immune to the psychophysiological effects might have a reaction?
Yes, I think that, I don't know if the virus, I've heard a couple of days ago the opinion of an Italian expert that he thinks that the virus is already losing power and it's not as dangerous as it was a few months ago. But I want to think from another point of view, from a more psychophysiological point of view. Right now, there are a lot of people with very, very high levels of stress because of all the situation, because of the fear of getting the disease, because of the quarantine, because of economical points of view. And stress, among other things, produces cortisol, and cortisol, among other things, affects our immune system. So I think that right now, because of all the things that we have lived, maybe we are more exposed, even if the virus is less dangerous, because of all the stressful situations that we have been living. I think that the second wave, it's almost a certainty from people who are experts in that field, from epidemiologists and virologists. They're almost sure that there will be a second wave near the winter or in the winter time. And maybe it would become endemic from each year and so on and so on. But right now, because of all the stressful situations as a whole we have been living, I think that we may be facing a different situation, but right now our immunological response could be from the social point of view could be less because of the stressful situation that we have all been living. So I think that, as I told before, applied psychophysiology could really play a key role, as simple as controlling stress in people, and in that way helping them to their immunological system to deal with the second wave of the disease. So I think that, yes, people who are experts in this field think that there will be a second wave, and I think that we should be starting to prepare ourselves for that second wave, so it doesn't be as bad as the first one. And I think that we still have chance to deal with it, and everything that deals with reducing the stress level should be work perfectly in these kind of situations.
That's actually a good segue to some of the other questions people are asking. So quite a few people are wondering what you specifically what specific device do you use or measurements do you use? And so I know that's a lot.
My specific device, the device that I use in my clinical practice,
or general methods. They're kind of wondering about that applied psychophysiology devices or equipment.
I think I do bio neurofeedback. I've trained in both, so I do bio neurofeedback even simultaneously. So the devices that I use are the ones that are capable of doing neuro biofeedback from a very good point of view, not the only ones that are just for biofeedback or just for neurofeedback. The ones that I use in my clinical practice from the practical point of view is that I need an equipment who is capable of managing both. That's the kind of equipment that I use. I also think that portable devices that can measure some some amount of physiological response of psychophysiological reactivity, maybe HRV. Of course, skin conductance and peripheral temperature could be a very good ally for our patients to have at home, and to make a follow-up through the app or through a web-based service, so we can make a follow-up and give instructions to our patients. That's the way that I think that's the most functionally way to work right now. Of course, I'm not talking about having the social distance of 4 feet between ourselves and our patients in our office. Of course, it's understandable that we need to have to clean all our equipment with each patient that comes to consultation, but I think that's not the real issue of the webinar. But indeed, from this point of view, in my clinical experience, I really use devices that help me do both at the same time, bio and neurofeedback, who are portable, of course, and with screens that are easily to understand by our patients, because we as specialists, we may be used to use screens that may be quite complex or something, and for us it makes totally sense. But I have found over the years that friendly screens for our patients that it's one of the best ways to get them involved into a treatment. So I think that portable devices, of course, most portable devices won't have the same sensibility as in-office devices, but I think that technology has evolved to help us do maybe the diagnostical point of view in our office and have follow-ups maybe each week of every 2 weeks, and the rest of the weeks and the rest of the days our patient working from home every day, and we are giving us and we are receiving the follow-ups from the different apps or web-based services, so we can modify if necessary the treatment or intervention, or to see that if everything is okay. I think that technology right now can give us that kind of tools to work from the proper situation, from a safe situation, to say it in a better way.
It should be noted that as hosts of this webinar, Thought Technology, we are an equipment manufacturer that creates tools for various biofeedback, neurofeedback, and other types of therapies. We'd be happy to have a discussion with anyone who's interested in learning more about how we have clinical equipment good for biofeedback and neurofeedback, as well as other devices that are best used for remote training.
No, and people who know me knows that I'm work with different devices and all that. So I think that that's why we are aimed to do. And for example, I've worked with Procoms and all that from nearly for 20 years. So that's equipment that I use.
Someone's asking, specifically, do you do remote training, and what do you use for that? They're looking for advice.
I do remote training, not since the COVID-19. I started doing remote training because I deal even with my supervised practice, even for BCIA certification. Not all of my students are in the same city as I am, so I was used to doing remote sessions, not only for COVID-19, but before with my students even in Spain and Portugal and Argentina. I'm in Mexico, but right now it has become maybe necessary for every point of view. My office is at the hospital, so that's another thing to take into consideration. My office, my consultation is at the tower of medical offices at the hospital. So when patients go to see me, they need to go to the hospital. Right now, going to a hospital, even though that we take the measures, and of course there are different areas of the hospital, but a lot of patients are not comfortable going to a hospital right now. So that has pushed me to use distance training and to use very different methods and distance training. For example, I used to own a couple of GSR devices that I didn't use them as much in my office, but right now I tend to give those devices to my patients also, not only the other devices that it can be multimodal feedback, for example, HRV and all that, but even the skin conductance and temperature devices, more simple devices, can be very useful for the patients to work at home. So right now, taking into mind that I work at a hospital, there are not a lot of people who feel comfortable to go to a hospital right now. So right now, for me, working at the distance has become a most important way to work with my patients. I think, for example, for 10 patients, 7 of them are remote training right now, and 3 of them agreed to go to the office with all the sanitary precautions, and of course. But right now, I think that people are a little bit worried about going into medical facilities or going into a health facilities in every way. So I think that this, of course, this will change in the few months, but we must get used to wearing the face mask and even and all kind of PPE, the personal protective equipment. But yeah, I work at distance, and I have found from my clinical experience that the results are great. I was a little bit skeptical from that point of view at the beginning, but right now I'm very, very well convinced that remote training works and works very well.
All right, I realize we're quite over time, so thank you very much, David, for spending the extra time answering some of these questions. Before I give you the last question, I just want to point out that quite a few people really liked your diagram, actually, that showed the 4 waves. It showed a different way of looking at that perspective, and they thought that was really clever. So final question for you all, for you, should I say, would be would it be reasonable to proceed in treating the effects of COVID-19 in a similar manner as the impact of something that's more catastrophic to your health, such as like heart attack or stroke?
Very good question. I think that we should all address every health situation from the most professional point of view. But right now, I would love to have a more specific answer, but COVID-19 has changed and is changing every day the way that we think about disease and even treatments and even symptoms and signs and all that. So until today, up to this day, the way that we work at the hospital is that we are thinking that everyone may be a potential carrier of the disease. So we have to follow the same protocols for everyone. That's at least, for example, in my consultation, when people arrive at the consultation, because as I told you, twice before I work at the hospital. The ones who are going to my consultation, I take their temperature and I have a portable oximeter and I see their oxygen saturation before they go into my office. That's a protocol inside of my hospital. But returning to the more specific question, I think that we should treat him more or less with in the same way. I think that COVID-19, from the metaphorical point of view, it's going to be the new heart attack from the ERs. Everyone are going to go into the ERs thinking that they have COVID-19 because of all the different symptoms. And I think that as time passes by and our immune system grows stronger and the virus may be weakened, I think that this may be changing in the near future. But right now, I think that COVID-19 will turn out to be the new heart attack of the ERs, and most of the times we're going to find out, and more and more with time, we're going to find out that not everything is COVID, of course. Most of the situations that we're going to face are more anxiety or stress-related situations. But even if we know that we are going to face more and more anxiety and stress-related situation, it doesn't mean that we have to first discard that it's not COVID-19. So I think that we are facing new protocols that we, even from the sanitary point of view, that will bring applied psychophysiology closer to the medical practice than before. We are going to adopt a lot of different protocols from the sanitary point of view that for the practice of applied psychophysiology.
All right, and with that, this brings our presentation to the end. Finally, once more, thank you, David, for the presentation. Thank you for spending your time with us, and thank you everyone who attended live, as well as those who may be reviewing this as a recording. Wish you all a wonderful day, wonderful week, and I hope to hear from you all soon. All right, bye-bye for now.